Today's session is entitled Withdrawing and Withholding, Distinctions and Controversies in the End of Life. My name is Joel Woot. I'll be the host today. We have some housekeeping to get through, and then I'll be turning it over to our speakers. Next slide, please. So this is just for the mHealth Fairview folks that are on. This is a reminder that we have a 24/7 ethics consultation service. Due to the changes in some of the ways that we communicate in the system, we can be contacted either through Vocero for the group that's called the Clinical Ethics Consultation Service. That's how you can get a hold of us on Vocero. The alternative is also just to place an inpatient ethics consult order through Epic, and then we will also be notified. Just also to emphasize that currently we are only really authorized to do clinical ethics consultation and provide recommendations for patients that are in the hospital that are inpatient. Next slide, please. Some housekeeping. So regarding questions, please use the Q&A function to ask questions or to follow up on questions, and also let the center staff know whether or not you're having any technical difficulties with the Q&A. Please do not use the raise your hand function. That should be disabled. This is also to let you know that we are recording these sessions, and the recording can be accessed at the bioethics.umn.edu website in the past events archive. The link is there. We have also enabled captioning. If you go to the bottom of your screen and click captions, you should be able to have captions live. Finally, there will be 3 ways to access the evaluation of the session. There will be one way, which is it pops up in our browser. There will also be a presentation details document that will be made available in the chat that will have a bunch of information about both this series and also other Center for Bioethics events and courses. And we'll also be sending a follow-up email. Next slide, please. For those people that are seeking credit, we can provide a certificate of attendance for continuing education. For the students that are seeking IPE credit, you must participate in a 15-minute post-event group discussion and also complete the reflection form. There are also some students that might be coming in from the biomedical engineering program. To receive the credit, you need to submit the name and the date of the event in a quiz on your assignment tab in Canvas. I think we're also going to be providing this information again in the details document. So there will be other ways that you can re-access this information, but we're going to move along because we want to get to the talk. Next slide, please. So let me take a few minutes to introduce our speakers today. First, we have Dr. Jaime Connerman-Sease. She is a clinical ethics assistant professor at the University of Minnesota Center for Bioethics. She's a member of our team at the Center for Bioethics that provides clinical ethics consultation services for the mHealth Fairview system. Her role includes clinical ethics consultation, policy development, and education for all the hospitals in the mHealth Fairview system. She's also a member of the UMMC Ethics Committee. Dr. Connerman-Sease's academic work focuses on disability bioethics, medicine and literature, and religious bioethics. By drawing from historical sources, she highlights novel solutions to modern-day healthcare problems. Her current project draws on the novels of Jane Austen to provide solutions to the marginalization of patients with chronic and incurable diseases in medicine. And her future work will continue to focus on the intersection of medicine, literature, theology, and disability. More background on her training: she completed her PhD in healthcare ethics and theology at St. Louis University in 2022. She was a student intern from 2020 to 21 in the program for ethics and theology at Common Spirit Health, where she assisted in clinical ethics consultation, policy development, and scarce resource allocation. In 2023, she received an Emerging Scholar Award from the Institute on Theology and Disability for her doctoral work on chronic illness, Jane Austen, and Christian theology. Next. And our other speaker today is Dr. Justin Penny. He is an assistant professor in the Department of Family Medicine and Community Health, the University of Minnesota. faculty for the University of Minnesota Medical Center Family Medicine Residency Program, also known as SMILES. He practices full spectrum family medicine, including hospital medicine, obstetrics, primary care, and LGBTQ plus comprehensive care through his joint appointment in the University of Minnesota for bioethics. He is also part of our clinical ethics consult team, providing clinical ethics service support for the mHealth Fairview system, and also serves on the University of Minnesota Medical Center Ethics Committee. Dr. Penny's current academic and research focus is the intersection of LGBTQ care and bioethics, care delivery, and medical education concerning transgender and gender non-conforming care, and also the needs of an aging LGBTQ population. Dr. Penny has a bachelor's in biology and also a bachelor's in classics from the University of Kentucky, and he completed his DO and MA in bioethics from Kansas City University. He completed his residency in family medicine at the University of Minnesota. He is board certified in family medicine and also osteopathic manipulative treatment from the American Osteopathic Board of Family Physicians, and he has also earned the HEC-C credentialing. Actually, both Jaime and Justin have that. So those are our speakers. Next slide. So a few extra final housekeeping details, and let's get going. These are the directions for the IPE credit for University of Minnesota students. There's going to be a link in the chat. Please click that link and then go to the session after that. Next slide, please. Okay, I think that's all the intro. I think we can transition over to Dr. Connerman-Sease and Dr. Penny. Thanks.
Thanks, Joel. Okay, found the unmute. Thank you so much. Yeah, we're excited today to talk to you about withdrawing and withholding, distinctions and controversies in end-of-life care.
We have no disclosures and no conflicts of interest. So before we get into our learning objectives, we want to open kind of before leading you on with some polls. So the first question is, and actually the first set of questions, physicians should always comply with a patient's request to withdraw life-sustaining treatment. I find it more physiologically difficult to withdraw life-sustaining treatment once it has been started than to withhold it. And it is typically more ethically problematic to withdraw a life-sustaining treatment once it has been started than to withhold it. So we'll take a few seconds to allow quite a few people to respond to these three questions and then submit.
All right, we are going to end the poll in about 5 seconds. So get your last answers in and we'll share with everyone the results.
So for the first question, we have mostly agrees, 27% strongly agreeing, 52% agreeing somewhat. The second question, kind of right down the middle, agree somewhat leading with 49%, disagree somewhat 21%, agree strongly 24%. And then that third question, agree somewhat, again, is our leader, with disagree somewhat being the second option. So the published results in a paper from 2016 has somewhat of the same breakdown, agree strongly and agree somewhat leading that first question. The second question, also the largest percentile, 42% in the study, 49% for us, were agreeing somewhat that it's more difficult to withdraw life-sustaining treatment once it's been started. And then the third question, also agree somewhat leading, typically more ethically problematic to withdraw life-sustaining treatment once it's been started. So it seems that our population here for this poll lines up exactly with our published results. So let's unpack a little bit of that.
Yes, let's unpack. I love that.
Have to play on words there. So our learning objectives, we want to understand the ethical similarities between withdrawing and withholding interventions. We want to explore how this is different. Withdrawing life-sustaining interventions is different than euthanasia, and analyze some common cases around these themes. Next slide.
Right. So this question about withdrawing and withholding really has a good grounding in the President's Commission on Foregoing Treatment. This commission set out in 1983, well, probably before that, results were published in 1983, to explore the ethical dilemma of withholding and withdrawing medical care at a time when medical technology was really rapidly changing the way that people die in the United States. So this group framed the question of foregoing medical treatment from the ethical obligations of providers, specifically questioning if it's ever appropriate to not use medical care if it's technically possible and available. Or rather, their question was, if professionals do not do what's technically possible, should they be held morally responsible for death, for the death of the patient? And the conclusion from this commission was ultimately no. Healthcare providers do not have an obligation to always use technology to sustain life. While medical technology can prevent death for a time, no technology can totally prevent death from occurring at all. So therefore, to hold healthcare professionals morally responsible for death itself at all times would be illogical and wrong. So rather, what they set out to say was that healthcare professionals do have an obligation to honor patient choices and act in the best interest of the patient and through evaluation of the risks and benefits to guide decisions on withdrawing or withholding medical interventions. So really, decisions to withdraw or withhold medical interventions should be made on an evaluation of risks and benefits in combination with patient preferences. So this has really remained the guidance on the conversation around foregoing medical care in the US since 1983. We could stop this webinar here. That's it. That's what we say, but we're not. We're going to dive deeper. We're going to go into some of these arguments. And that doesn't really mean that this topic is totally settled. There are lots of complexities that arise as we apply this to patient care. So one of the central philosophical debates around the President's Commission question, when is it appropriate to forego medical treatment, is the distinction between actions and omissions. So if we narrowly rely on a simplistic application of the Hippocratic Oath statement, do not kill, to guide us in questions about withdrawing and withholding, we might conclude that actions that directly lead to the death of the patient are killing and therefore are morally wrong, while omitting to act is morally appropriate. And we might say something like it's ethically inappropriate to cause a patient's death, but ethically appropriate to allow a patient to die. But this gets really muddied when we look closely at what it means to cause a patient's death, looking at technical cause from a philosophical perspective. So technically, turning off a machine that sustains a patient's life is an action that leads to the patient's death. So in the most technical philosophical terms, it's a cause. But most clinicians would say that when they're actively turning off a ventilator, say, according to a patient's wish, that they're allowing the patient to die. They don't see it as that direct action. So this action of turning off a ventilator, losing my notes. So this action of turning off a ventilator is technically, right, a direct cause, but we don't see it that way. And even though it leads directly to the death of the patient, it is morally appropriate if it's in accordance with the patient wishes and in an evaluation of the risks and benefits. So the question of ethical appropriateness isn't really about the difference between an action or an omission. What it really is about is a question of intention. Why are we making the decision to proceed with this particular action? The intention behind the action holds the moral weight and determines if the action or the omission is morally appropriate or not. So in medical care, it's important to focus on the intention because actions or omissions can both lead to morally wrong deaths as well as morally appropriate deaths. For example, it's ethically appropriate for a physician to withdraw ventilation, which is an action, if the patient with capacity expresses their desire to stop life-sustaining treatments, which they feel to be burdensome. But it's ethically wrong for a family member to withdraw ventilation, that same action, to gain access to the patient's life insurance payout, right? The same action, but two different intentions, which determine ultimately if an action was actually ethically appropriate or not. So the action itself, like turning off the ventilator, doesn't hold the moral weight. It's the intention behind the action that carries moral weight. So is there a moral difference between action that results in death or omission that results in death? Only the intention. So some instances of an action that result in death will be morally wrong, but while others are morally right, and some instances of omitting to act will be morally wrong, while others will be morally right. So intention really is key to exploring the question of withdrawing and withholding. So now that we've discussed that intention is the most important factor to explore, let's look at how intention impacts the ethics of withdrawing and withholding. So if intention determines the moral appropriateness of an action, that means there's no meaningful ethical difference between withdrawing life-sustaining treatment and withholding life-sustaining treatment. So if it is ethically appropriate to withhold an intervention in the first place, then it's ethically appropriate to withdraw that intervention after it has been started. Withdrawing does not hold any more moral weight than withholding. So this is called the equivalence thesis in philosophy, and it's when two seemingly different actions are actually ethically equivalent. They are the same from an ethical perspective. And we can see this equivalence thesis in this quote from the President's Commission, which states, a justification for not commencing a treatment is also sufficient for ceasing that treatment. So the action of starting or stopping is not the ethical concern here. We're not really concerned with the action of starting or stopping, if that's okay. It's the justification or the intent behind those actions which determine if the action or omission is ethically appropriate. So this is because the appropriateness of a medical intervention is determined by its potential to benefit, weighed against the harms that it causes. If a medical intervention would not benefit the patient, it's appropriate to withhold that intervention from the patient. And therefore, if intervention's benefits no longer outweigh the harms, it's appropriate to withdraw that treatment. So what role does patient choice play in all of this? Patients should be offered the choice between appropriate medical interventions and decide which interventions to pursue based on their own deeply held goals and values and personal preferences. But informed consent is not always this simple, right? And we'll explore some of the complexities that arrive when evaluating risks and benefits, and then when those conflict with patient wishes and values in our upcoming cases.
So the first case to kind of apply some of this philosophy to a case, John, 85-year-old patient, has been on hospice care for several months. He's had his health deteriorate. He has a cardiac implantable device, a pacemaker. It's been implanted for several years. It regulates his heart rhythm. It's worked great. He now finds himself experiencing frequent episodes of shortness of breath, fatigue, discomfort. He expresses wishes to turn off his pacemaker. He explains that he no longer wants to undergo procedures or interventions. He doesn't want his death to be dragged out. He is clear he doesn't want to hasten his death, but simply wants to allow nature to take its course. So John's physician calls our ethics team and is concerned that turning off a pacemaker is euthanasia and it would be killing the patient. So we have a poll question that says, do you agree with that statement? Do you agree with this physician's concern?
All right, we'll be ending the poll soon, so get your decisions in.
Seven percent yes, 80% no, 12% unsure.
So this case is a great example about the distinctions between withdrawing treatment, foregoing treatment, and euthanasia. So what should you do when your action as a healthcare provider will directly lead to the death of a patient, as in John's case that we just mentioned? Intention here, again, is key. So, and it really goes to the difference between how we define euthanasia and how we define withdrawing treatment. So euthanasia is the introduction of a new intervention or a pathology like a lethal agent, the intent of which is the death of the patient. So in contrast, when a patient dies after life-sustaining treatment is refused, withdrawn, or deactivated, the underlying disease is the cause of death. In this latter situation, the intent is freedom from an intervention that is determined to be burdensome. So in John's case, we would advise this physician that euthanasia is ethically distinct from a patient's choice to forego medical care. Turning off a pacemaker is ethically appropriate and is not euthanasia, as the provider is not introducing a new agent with the intent to cause death. And additionally, when it comes to questions of quality of life, the decision of whether the burdens outweigh the benefits is up to patients with capacity. So forcing patients to continue to live with interventions, say if we don't turn off John's pacemaker, that patient has determined to be more burdensome than beneficial, it does not demonstrate respect for persons and is a very harmful form of paternalism. So in general, that's the distinction between withdrawing care and euthanasia. And I want to pause on deeper considerations of euthanasia, as well as questions about medical aid in dying or palliative sedation. We will discuss those at our next Unpacking Bedside Bioethics session in August with Joel Wu as our speaker. These topics deserve a lot more space for thorough discussion than we can give here. But that's the particular distinction between these two issues.
So now we have a few more poll questions, kind of broadening back out. You can open the poll and I'll start reading the questions, Jaime. I believe that persons with decision-making capacity should be allowed to stop any medical treatments they no longer want. I believe any death resulting from a patient deciding to withhold life-sustaining treatment is suicide. And I believe any death resulting from a patient deciding to withdraw life-sustaining treatment is suicide.
Some good results coming in. We'll end the poll soon, so get your final statements in, your final choices. All right.
So part number one, strongly agree with 66% and then agree with 32%. No, strongly disagrees. Question number 2, no strongly agrees, 2% on the agree, kind of a mirror image there, 34% on the disagree, 63 on the strongly disagree. And then number 3, 0 on the strongly, 2% on agree, 35% on disagree, and 63% on strongly disagree. And I wrote those numbers down to compare to our next slide, which is another published poll result. And this time from a 2021 paper in American Journal of Bioethics. So this table is not quite as nice as the first table. The other one had some wonderful color imaging to help people with different needs match those answers. But for number 1, we were looking at the first question there in the table. So that one, 79%, said strongly agree, where we said 66% said strongly agree, and had kind of the same breakdown. 0 strongly disagrees. The second question was the second line there. So again, mirroring the same, very few strongly agrees, and increasing to strongly disagree. We had 63%. This study had 61%. And then the third answer is the third line, where we have pretty much the same breakdown. We had 35% with disagree, they had 29%, and 63% is what our poll had, and they had 67% with strongly agree. They asked some further questions. There's other questions around religious beliefs, morality. We will explore a little bit of that in some upcoming cases, but we're not centering on that this time.
So I think this poll is a really great way to explore the relationship between capacity, end-of-life, choosing an end-of-life decision as patients, and suicidality. What is the difference between a patient who says, I'm ready to die, and a medical team that says we're accepting of this decision, and a patient that says, I want to die, and a medical team says that's not an appropriate decision to make? So in the evaluation of risks and benefits of an intervention is really a key part determining if withdrawal is ethically appropriate, and capacity separates out the concern for suicidality from an appropriate medical choice. So suicide is defined by distress, and that is a significant thing that makes it different from an appropriate withdrawal of treatment choice. So episodes of distress or episodes of psychiatric distress would be a suicide decision that prevents decision-making capacity, right? Suicide is something that is defined by psychiatric distress that prevents capacity, whereas withdrawal of treatment is defined by an assessment of the risks and benefits of a particular treatment. The patient is making an assessment, they have capacity, they're able to evaluate risks and benefits and integrate that into their own deeply held values. So if a patient does lack capacity, say due to depression or other psychiatric illness, it really might or might not be appropriate for them to make a choice to withdraw treatment. But this depends on a really thorough examination and evaluation of the risks and benefits of that treatment. So if the intervention is beneficial and the harms are relatively low, it would likely be inappropriate to allow a patient who is actively experiencing a psychiatric illness like depression to make a decision that results in their death. However, this becomes more complicated with interventions that have less likelihood to benefit the patient. So as the benefits of an intervention decrease and the risks increase, allowing patients with psychiatric illnesses to make end-of-life decisions is likely more ethically appropriate. And this is because capacity is really issue specific, and the presence of psychiatric illness does not necessarily mean that patients globally lose capacity. So patients with psychiatric illness can still have values and judgments that are valid and should be respected, which is why an assessment of capacity is so important in exploring these concerns about withdrawal or suicide. So if you have a patient who does have a psychiatric illness and is also asking to withdraw care, an evaluation of capacity, assessment of the risks and benefits is really key. I'd say involve ethics, but it does not necessarily, psychiatric illness does not necessarily mean that a patient doesn't have capacity to make an end-of-life decision. And making withdrawing decisions to withdraw care is not the same as a suicidality. These are not the same categories, and they're defined by distress, right? One is defined by distress, the other is defined by an evaluation of risks and benefits.
So case 2, a pediatric case. Parents of an infant born at 28 weeks gestation, so very early, informed that their child has trisomy 18 and a severe heart defect, grade 3 VSD, that is not surgically correctable. The patient is on mechanical ventilation, has an NG tube. The care team informs the parents that their child will not be able to live outside the hospital and recommend transitioning to palliative-only plan of care, which includes withdrawing the ventilator and feeding tube. The parents express that it's okay to stop the ventilator, but there's a request that they continue the feeding tube in accordance with their religious commitments. They state that withdrawing the feeding would be starving the patient and ethically wrong. Do you agree with the parent's statement?
Great, so we're getting some good responses. Maybe 10 more seconds and we'll close the poll. All right.
So we have 16% with yes, 60% with no, 24% unsure. So a little bit more, not really a solid opinion one
Yes,
way or another from our group.
variation in our audience.
Variation.
Yeah. So let's talk about with nutrition and hydration, specifically artificial nutrition and hydration. Is it ever appropriate to withdraw nutrition? And does nutrition hold a unique place in medical ethics? The question of withdrawing nutrition and hydration differs based on religious and cultural perspectives, but it really can break down into 3 main categories. So first, many groups see nutrition and hydration when provided through medical means like a feeding tube or TPN, something like that, as the same as all other medical interventions. So ANH therefore is only appropriate when the benefits outweigh the risks. And there's no moral obligation to continue ANH if it no longer provides a medical benefit. So there's no obligation to offer ANH if it will not contribute to either a palliative or a restorative plan of care. So that's this first group that sees ANH as any other medical treatment, any other medical intervention. Second, there's a group that explores the use of ANH on a case-by-case basis to determine if it's ordinary or extraordinary. Ordinary uses of ANH are ones where ANH is that long-term source of nutrition for the patient, and it's therefore seen as essential to their long-term survival. For instance, in patients with, say, chronic acute disabilities, or have relied on a feeding tube for gastric conditions or whatnot. These are patients whose long-term survival relies on a feeding tube, and therefore withdrawing it would be considered ethically inappropriate, as that's their ordinary food source. Extraordinary sources of uses of ANH are those which are used as medical therapies to achieve a particular medical goal. So foregoing extraordinary ANH is morally appropriate, where foregoing ordinary ANH would be considered morally inappropriate. And finally, we have the view that ANH is the same as food and therefore is ethically required. So this perspective holds that if a patient is unable to swallow or consume food on their own, it's ethically required to use all medical means to feed the patient. So ANH would be ethically mandatory. So who belongs to each group? Well, unfortunately, we don't have a chart, and it's actually not that simple. Even with religious groups that have relatively hierarchical kind of perspectives, like the Catholic Church, different adherents to each faith hold all of these perspectives, and each cultural group will hold all of these perspectives. So there's no one approach that all Muslims or Christians or Hindus or Jews hold, for example. Each faith group has members that will express each of these viewpoints. So if you have a patient that is expressing this perspective from a religious commitment to food or something like that, you should work with chaplaincy and that patient and family's particular religious leaders to understand how commitments to food work out to medical situations. There could be a case where families might express one thing, but when you involve religious leaders, it turns out that their religious leaders recommend a second thing. So involving chaplaincy, involving religious leaders in conversations about ANH if the conflicts arise is really critical and really key.
I want to emphasize that too, because I think that's an important distinction that we often miss in the art of medicine. That we have maybe religious commitments that are very, very shaped by cultural influence, family influence, and other values influence. Um, Overgeneralization is almost always problematic. So you cannot um, align family A with family B just because they share the same religious ideology. So their cultural, the things that have carried them through life, past experiences, all weigh very heavily, and they might seek faith as a form of support, but their context is often completely different. So I just want to like go off book a little bit and
Yeah,
highlight that point.
absolutely. Yeah, absolutely. And so in light of that, for the last case that we discussed, our recommendation would be to actually work with the families and religious leaders to explore this particular parent's perspective on ANH. We'd also would consider what harms might come from accommodating this request. Would it be appropriate to accommodate a request like this? Would it prolong death significantly, or would it not prolong death significantly? Is there a perhaps narrative reason why accommodating this request might be ethically appropriate? And finally, we would consider if it would be ethically appropriate to withdraw over parental objection, which we will discuss later, the concept of and the difficulties of withdrawing over objection, the ethical challenges, let's say.
Mhm. So that moves us to case number 3. Alex is a 25-year-old patient. They are admitted to the ICU and they have severe limb ischemia. This is from IV drug use and sepsis. They're currently on ECMO and CRRT, which is continuous dialysis. Alex's grandparents serve as their legal surrogate. They are unable to, Alex themselves are unable to communicate because of this illness, and there is no documentation of Alex's values, no advance directive. After a few days, Alex's limbs are necrosing. It's clear that they have not had any indication of recovery. They are clinically terminal. The team calls a care conference. They share their conclusion. They are recommending withdrawal of both life-sustaining interventions, both ECMO and the continuous dialysis, and transition to a comfort-focused approach. Alex's grandfather protests, saying, "You cannot stop the machines that will kill them." Do you agree with this grandfather's statement that stopping ECMO and CRRT would be killing the patient? Yes, no, unsure.
Great. Great participation. We'll be ending the poll soon.
Five 5% yes, 84% no, 11% unsure.
Great. So in Alex's case, would we disagree with Alex's grandfather that turning off machines is not ethically equivalent to killing a patient? So we would. I would. Turning off a machine is not ethically equivalent to killing a patient, but rather it's a decision that's made on risks and benefits of a particular treatment. In this case, we don't have Alex's wishes and values, and therefore we do rely on Alex's grandparents as surrogates to represent their values. But it's really not clear here if Alex's grandfather is expressing that Alex would have wanted to remain on ECMO indefinitely or not. So in a case like this, we would recommend escalating and exploring what it means to withdraw over surrogate objection. To really see if ECMO and CRRT are considered inappropriate medical treatments in light of Alex's necrotic limbs and imminent death. So when our center, we rely on a 5-society critical care society statement on futile and potentially inappropriate treatment, which designates out and defines out what is futile care and what's potentially inappropriate care, and when is withdraw over objection appropriate. So medical care would be futile when it does not physically accomplish the physiological goal. So if that intervention is not actually, so if the intervention is potentially prolonging death, it's actually likely not futile because it's very probably, in a narrow sense, accomplishing a physiological goal, which is sustaining the patient's life. So futility is really narrowly defined as a medical intervention which does not accomplish a physiological goal, such as using antibiotics for a virus, right? There's no ability for that treatment to address the underlying medical issue.
And people use the word futility when they really mean non-beneficial.
Right.
I would argue that non-beneficial is your really big umbrella term, and futility is in that umbrella. It's a more charged word. We get excited about that word, but it's specifically when A does not accomplish B.
Yeah, the nuance of it is actually important to notice from an ethical perspective. So care that an alternative to potentially futility would be potentially inappropriate care. So care is potentially inappropriate when it might technically accomplish that physiological goal, but competing ethical obligations like beneficence or non-maleficence would justify not using those treatments. So we can see this kind of care, potentially inappropriate care, in the intensive care unit, say, when the patient will not survive outside the acute care setting, right? While we might technically be, sustaining the patient's life, if there's no ability for that patient to survive outside of that intensive care unit, that treatment might be potentially inappropriate. And secondly, it might be potentially appropriate if the patient has an irreversible severe neurologic injury that prevents them from perceiving the benefits of treatment. So in the case of potentially inappropriate treatment, the 5 critical care societies that we rely on for our guidance in this recommend following a procedural dispute resolution process that involves ethics, risk management, hospital leadership, and an interdisciplinary review process to determine if care is narrowly futile or if it's potentially inappropriate. And if care is potentially inappropriate and a procedural review process takes place, then it might be ethically appropriate to withdraw over objection. Which brings us to the challenges to the current state in the US, where withdraw and withholding are seen as equivalent and based on patient preference and the evaluation of risks and benefits. So first, as I discussed on that slide with ANH, there are religious and cultural groups that hold that withdrawing is always morally problematic and do not see intent as a meaningful difference in the debate. So for these groups, any action that leads to death, like withdrawing a ventilator, or an omission, like not providing ANH, would be morally prohibited. And this perspective is really directly in conflict with the view that withholding and withdrawing are morally equivalent actions. And this can lead to a lot of conflict at the bedside when patients and families hold these views, and providers and the medical institution that supports them holds the view that withdrawing and withholding are morally equivalent actions. Second, we have a conflict when, in the second category, medical providers have no ethical obligation to offer treatments to families if those treatments do not benefit the patient. However, if a currently used therapy no longer benefits the patient, the decision of whether to continue or not isn't with that expert medical team, it's with the patient and family. And this can lead to conflicts when patients and families request to continue therapies that are no longer medically appropriate, and really calls into question where authority lies. Why does authority lie with one group before it happens and another group after that therapy is already occurring, if these two actions, withholding, withdrawing, really are morally equivalent? And finally, if patients and families refuse to consent to withdraw treatment that no longer benefits the patient, the care team is left considering if withdraw over objection is ever ethically justified. Which overall calls into question this ethical equivalence thesis, if withholding and withdrawing really are ethically equivalent. This doesn't seem to practically be the case, as we rely on informed consent for withdrawal, but don't rely on informed consent for withholding necessarily, right? Withholding is sort of narrowly informed by the potential to benefit the patient. So it brings up if these two actions really are ethically equivalent, then why do we have two different practices of informed consent for each of them? So these are some of the current unanswered, for potentially open questions to this debate on withdrawal and withholding that are unanswered, currently being discussed, and perhaps we can discuss more of these during our Q&A.
So I'll leave this conclusion slide up as Joel comes back on to look at some questions that have come in through the discussion. Remember that we've explored the similarities between withdrawing and withholding. We've covered that withdrawing care is not ethically equivalent to euthanasia. We've explored some religious cultural commitments around artificial nutrition and hydration. And when there is the need to withdraw or change focus of care over objection, that there needs to be a procedural process.
Great. Let's just jump right into the Q&A because we have some really insightful and I think really precise questions here. There's a series of 2 or 3 questions that are related. So I'll sort of pitch them in order, but they're relating to the notion of voluntary stopping of eating and drinking, the withholding of food, and also potentially eating disorders. So the first 2 questions I'll sort of batch together. So one person writes, I'm hearing this presentation in the context of current decisions by patients to begin the process of the voluntary stopping of eating and drinking. So this is when a patient who either has decision-making capacity or through a directive has said that at the end of life, that they want to voluntarily stop eating and drinking. They do not want to be involuntarily given artificial hydration and nutrition. But they also would hope, and the clinicians have some obligation to manage their symptoms, right? So voluntary stopping of eating and drinking. Does any of this analysis regarding the difference between withholding or withdrawing apply to VSED? Another person also writes, I'll read exactly what they write because I think it has some language that may be worth evaluating. So can you address the recent movement in Minnesota to withhold food and fluids even though the person is still able to swallow? So physiologically able to swallow, right? But in following potentially a refusal, or maybe not even so sure about that, withholding food and liquids. How do we think about VSED?
I want to jump in to say, so some of this will be deferred to the next Unpacking Bedside Bioethics, and I'm thinking of the opposite of withholding, which would be compelling or forcing. And I think that that would be very ethically problematic to force an intervention upon someone when they have expressed goals and values to not want that thing. Now, VSED often has something called a Ulysses contract, where somebody in a state of mind sets up some plan or procedure for when they will eminently lose capacity to rely on their goals and values when they were in a capacitated state and not in a later state. Interestingly, a mirror to this is a birth plan in a labor contract. When somebody says, I do not want an epidural, I do not want these things to support my natural labor, even if I'm begging for an epidural later, don't do it. So that's a real-time active thing in the world. But I think the intricacies around VSED really need to be explored at the next
That's
unpacking,
right.
unless you
And
have some other statements, Jamie.
yeah, I would say that the question of withholding and withdrawing is different from VSED, because VSED is actively asking a provider to provide an intervention to minimize the harms that come from a patient's choice to stop eating and drinking. And so versus if a patient no longer is able to swallow and they say, I do not wish to have something like a feeding tube placed, that's an informed choice to forego treatment.
Right.
Now, the second
Dementia
question,
would be the case there.
right, and the
Advanced
second,
dementia.
yes, the second question of the movement in Minnesota to not offer, I've not heard any providers who are not offering feeding tubes or interventions to people who do not wish for them. So it would be patient-informed choice that would be guiding the decision, or if they're no longer, if they are able to swallow and they do not want them, those interventions, that is an informed refusal. However, if a patient is able to perceive the benefits and wishes for that intervention, I have not encountered a situation where they have not been offered that intervention. So that is not something that I'm familiar with or I have seen in our practice.
Great. So this actually is a good segue to a couple other related questions. So these next two questions involve the idea of the principle of double effect. One person asks, how do you see the principle of double effect in these circumstances? Another person asks, in the case of whether or not you're introducing a new agent, when a patient moves to comfort cares and morphine is given to reduce air hunger, could that be considered euthanasia? So how do we think about withdrawal or potentially the addition of another agent in these circumstances?
That's right. That's a great question. I would double effect. So yeah, this is exactly double effect. This conversation on withdrawing and holding relies on that doctrine of double effect. And double effect requires that the intention, the action itself be morally appropriate, that the intention is good, that they're proportionate to one another. And so in this case, we see things like turning off a ventilator being that itself is not a, the action itself is not intending death, right? And it's proportionate to the intention to provide freedom from burdensome intervention is proportionate to the action itself, which would be allowing a patient to die from the disease and the injuries that they have. So yes, double effect, absolutely. This is it. And secondly, when we think about introducing a new agent, that's also double effect. So and that's something that we will talk at the next unpacking bedside bioethics with palliative sedation is it ever appropriate to introduce a new agent? If that new agent reduces suffering and it's proportionate to the effect, and in the case of patients who are imminently dying, it's appropriate, but only in the case of patients who are imminently dying. And so I will also kind of say, let's wait to explore that in more detail with more nuance as we in the next unpacking bedside bioethics session.
I think it's worth emphasizing that the really important carryover that I'll probably refer back to this talk on is the importance of intention, right? Because one of the central parts of the doctrine of double effect is that the intention is actually to alleviate the symptoms, because there are no other effective ways of alleviating those symptoms, and that the intention is not to hasten death, even though a subsequent unintended effect may be the hastening of the death. Those are some of the really critical features of the doctrine of double effect.
And it really goes to show why intention, when we look at actions themselves, why we need to look at intention behind the actions, because actions themselves can actually be so complex, right? And the same action with different intentions can lead to whether that action is morally appropriate or not, whether we consider it ethically appropriate.
Right.
Great question.
These are very good questions. So another frequent issue that arises is the decisions about either the withholding or the withdrawal for patients who do not have decision-making capacity, the role of surrogates in making that decision, and then also potentially how clinicians would make a decision for otherwise unrepresented, unbefriended patients for whom we don't actually have any indication of their prior values. How do we think about making these decisions on the basis of either a surrogate or in the absence of a surrogate decision maker?
I can jump into this for the first part. So a surrogate's duty is to be a spokesperson for the patient, period, full stop. A surrogate should not and ought not to ethically make their own decisions and apply them to that patient. So if there's an advance directive that says, I would never want a ventilator, and there's been recent discussions documented in the chart that the patient wouldn't want a ventilator, a surrogate cannot come in and compel a medical team to put on a ventilator. And I think this happens a lot. We think that, oh, the surrogate overruled the directive. Well, that is only applicable very narrowly if that directive is old, outdated, or there's evidence otherwise that there's been a change by the patient to overrule their paperwork and it just didn't get filed. So I think that's something that we see often, all the time, and it's quite a few of our consults where there's paperwork that was found where a patient didn't want something or did want something, and a surrogate is saying the opposite. So we come in to help identify really what the goals and values of are the patient and not necessarily the surrogate imposing. Because if the surrogate is coming in and imposing their own beliefs, then we actually remove them as a surrogate. We claim that they're not acting in good faith, they're not acting on behalf of the patient, and we remove them.
So
And that is an ethical and a legal process.
we would transition then to best interest standard and exploring, and that's essentially what we use for patients who have no surrogates, who have no family, who have no next of kin, no neighbors who can speak on their behalf. We use best interest standard to explore what is in the best interest of this patient when we don't know their goals and values. For patients who are truly unrepresented, we have a procedural process that we follow that involves reviews with ethics and risk, just to make sure we're not missing anything, that if one provider's perspective that a treatment is non-beneficial or inappropriate, we involve other providers to make sure that there's agreement across the medical team, across people who are potentially, not involved in this particular patient's care, to really explore, is this continuing treatment appropriate for this patient or not? What is in their best interest? And ultimately, this sometimes leads to withdrawing and sometimes it doesn't. Especially this is in conflict with the process of legal guardianship. So often do you have to wait for an unrepresented patient to get a legal guardian to make a medical decision like this? We would recommend no, that urgent or time-sensitive medical decisions do not need to have a legal guardian, that following a process to explore the benefits and the risks of these interventions would be appropriate. Legal guardianship takes a very long time to secure, depending on your state and your county. And it's not really appropriate for short-term or immediate medical decisions. It's more appropriate for people with long-term capacity needs who will need a long-term assistance with decision-making.
All right. I think we have maybe another minute or two. I think I want to ask some more sort of interesting tangential questions. I want to get back to a really interesting question someone asked about intention. And so they write, I'm curious about the intersection between ethics and diversity, equity, and inclusion issues. I understand that intention is important in ethics, but I've also heard in DEI work that while intentions are important and that a person can be well-intentioned, they can also still cause harm. How do you reconcile this? Is intention, in other words, how do we deal with these two different approaches? Is intention sufficient, or is it need to be something that's intention plus?
That's such a good question.
I'm not sure how to actually respond to that. I'm thinking around, I think intention plus is a really good idea. And I think about things like accommodations and in a disability framework, that there is a role of society and of the general of the establishment to make accommodations, and the legal term is reasonable accommodations. So then there's a difference on like what is reasonable, what is not reasonable. I think here too, whether this is an accommodation around a care plan, or are we able to accommodate patients' values and preferences into the medical reality?
Mhm.
And I think that is how I would answer that question, is many times, yes, and many times, no. We cannot indefinitely prolong life. We cannot indefinitely provide resources. And that is where justice and resource allocation also balances a patient's autonomy.
Right.
I will also say that when you're anticipating taking an action, intention matters. But the result of that action, we can see sometimes might still lead to harms. And we are still responsible to address those harms that result, even if our intention was good or not.
Right.
So, well, even if our intention was good, definitely if it was not, but even if our intention was good. So the responsiveness to the results of that action is really critical, and being able to respond directly to harms that occur and say, wow, this harm, we couldn't have foreseen that harm from occurring. And that was not our intention that harm occurred. But since this harm has occurred, what are we going to do to, to seek justice, right? To accommodate the results of this action that were harmful.
Right.
And so the accommodation happens at the end. A reflection, I think, would be critical, and changement and adjustment to action based off of review, which is why having reviews is so important. But should we hold people, morally or legally responsible? Probably not, right? Because we can't foresee all harms that will occur. But foreseen harms and actions that lead to foreseen harms, that's a different thing from actions that lead to unforeseen harms without the intent behind them.
And that's in alignment with a trauma stewardship and trauma-informed care approach too.
Well, thank you, Dr. Connerman-Sease, Dr. Penny. This was excellent. I'm sorry that we weren't able to get to a long list of otherwise excellent questions from this group. So this wraps up our episode of Beyond Bedside Bioethics. In that prior slide, that was the information for the IPE students. And just a quick shout out for the next webinar. I will be doing one entitled A Patient's Last Chapter, Ethical Considerations for the Voluntary Stopping of Eating and Drinking, Palliative Sedation, and Medical Aid in Dying. I don't know if we have another slide. Oh, we do have another slide. So this is a pitch for some courses that Jaime and I will be teaching this fall, based at the Center for Bioethics. Jaime will be teaching a course on disability ethics, and I will be teaching a graduate level, more intro class to biomedical ethics. For more information, you can either look at the follow-up information that will be sent, and there's also this QR code that you can do a quick snapshot with your phone. I think that's it.
Great.
Thanks, everyone.
Thanks, everyone.